Okay, good afternoon.
Good afternoon.
Good afternoon. Welcome to the next talk in the CrySP speaker series on privacy. It's our great pleasure to have Professor Kelly Caine. Kelly is an assistant professor in the Human-Centered Computing Division at Clemson University in South Carolina.
Where is Clemson?
South Carolina.
South Carolina.
Yeah. And Kelly works on psychology and human factors in computing with particular application to such realms as security and privacy and health informatics. And we're going to see a great talk today, merging all those different things. Continuing on our recent theme, apparently, Kelly, our theme of Georgia Tech, Kelly received her PhD in 2009 from Georgia Tech. And we're very pleased to have her come talk to us today. Let's welcome Kelly.
Thank you so much. Thank you, Ian, for that lovely introduction. And thank all of you for having me and for inviting me today and for coming in this afternoon. I have to say, being from the South and being the South of the U.S. and being back in the South after a few years in other places around the country, the hospitality is rivaled here, maybe even outweighing our Southern hospitality. So I have felt very welcome here, and I've had great conversations with all of you, and I'm looking forward to continuing those conversations after today. At the end of the talk today, there will be time for questions. So thank all of you for having me, and thank you for giving me such a warm welcome here. I'm going to be talking about enhancing patient privacy via user interface tools today from a human factors perspective. It's slightly different than coming at this from a computer science perspective, but it's an aspect of computer science. And I hope that you'll be open to the ideas that I present and think about them. If you're not used to thinking about things from a user perspective or from a human perspective, I hope that you'll let yourself today get into that mindset and think about what it would be like for your mom or for your grandmother or for your kid or for some of your neighbors to use the technologies that we're talking about rather than imagining yourself using them. This being a university, I thought I would start with a little quiz this afternoon. So if you would like, you can close your eyes and then you don't have to feel embarrassed about raising your hand, but I do want everybody to raise your hand. Have any of you ever thought about what's in your medical record? So I definitely have thought about what's in my medical record. Okay, a few of you. Is there anything, when you think about the things that are in your medical record, that you wouldn't want to be public information? Yeah, there's definitely stuff in mine that I wouldn't want to be public, but fewer of you. Maybe this has to do with being a Canadian audience. You have this wonderful medical system that I hear great things about here in Canada. And I do apologize in advance. My work is a little bit US focused, but I think there are applications here for Canadian audience and also around the world. Do you think about who has access to your record? Yeah? Okay, still quite a few of you. I think about that sort of thing too. Do you think about whether information from your medical record has ever been sold? Okay, and to whom it might have been sold? What about in anonymous form? Is it possible to anonymize your medical record? Is that something very personal that maybe it's not possible to be anonymous? So thinking about all of those questions in the context of the talk today, I think will be helpful. This is an original copy of the Hippocratic Oath and a relatively modern translation of the Hippocratic Oath. What you'll see bolded there is a comment that is, "I will keep secret and never reveal health information." So this comes from the Hippocratic Oath that all doctors take, all physicians take when they're going to become a physician. We can think about a lot of reasons why this might be an important thing, right? You can imagine that in your own mind. Why is it that that the Hippocratic Oath might have settled on this part? I will, as a physician, as a care provider to you, keep this information and not reveal it to the world. It's primarily because if you don't provide that kind of confidentiality to a patient, they're going to be less likely to tell you all of the information that you might need to know as a care provider to give them the best possible care. If you are going to a physician with something that you consider potentially embarrassing, some information that might be potentially able to be used against you later on, you would want that person providing you care to assure you that they wouldn't share that information with the wider public. What I'm going to talk about a little bit today is kind of delineating that a bit. Not only are we considering whether do we want that information to be public versus do we want it to be completely private, only shared with you or only with one physician potentially, but what are the gradations that occur in a health system there? What does it mean to have privacy in a medical record system? What does it mean when we are moving to an electronic medical record that can be reproduced many, many times over, that can be shared with many more providers than it could possibly have been shared with in the past? And indeed, this has huge promise. This is from the National Committee on Vital and Health Statistics in the United States. The vision is for electronically shared information to vastly improve healthcare. The idea is if we can collect information electronically, if we can aggregate that, if we can analyze it, if we can have it be available at the point of care, we can reduce costs to the healthcare system, and most importantly, we can provide better care. All right? The idea is we can use this data, we can make care better by analyzing all of this and putting it into place, not only for individuals, but also at a population level. That vision has this huge assumption that I think hasn't been fully considered necessarily. The vision assumes that you're willing to share with your doctor, with your physician, with anyone that you seek care from, your data, right? Data about you, data about your health. Well, that might include something like your blood pressure, simple check that you go in and have when you see your doctor, when you see your nurse or care provider. It might include the variety of medications that you take, maybe the over-counter medications, vitamins. Maybe it also includes personal tracking, like the Fitbit that you wear on your hip or the step counter that you wear. Maybe it's data taken from a phone that tracks how much you move throughout the day. Maybe it's a sensor in your bed that tells your care provider how long you sleep and if you have sleep apnea or if you roll around all night and aren't getting that sound sleep and enough REM sleep that you really need. Maybe it's whether or not you choose to have the burger that was on the menu today when I had a really lovely lunch across campus, or whether you chose something a little bit more healthy. Maybe it's whether you live in a city like Waterloo that's really beautiful and has very clean air that's fresh to breathe, or if you live in a place that is highly polluted. Maybe it's your genetic information that can predict more than we can even possibly know right now about you and about your future health and about the future health of your family and your children and people who aren't even in this world yet, okay? It's what isn't related to health is kind of the question that I like to ask when I am talking to an audience about this. Everything that we do and everything that's around us can contribute to our health throughout our life. So you have to be willing to share all of that if you want to get the absolute best care and the best knowledge about what causes and what's associated with different health conditions. So this is a representation that visualization that LaTanya Sweeney's group created of a data map or a health data map, and it shows different places that health information in the US is shared sort of by default or automatically. One thing that I think here you can see at the very top is it says you the patient, but we don't really have good access right now to our own data. Do most people has anybody ever here seen their entire health record? Yeah, I have never either, and nobody raised their hand. So saying that that dot at the top is you, the patient, has access to it is a little bit potentially problematic. But all these other people do have access to your data. So in the US, the CDC, the coding, transcription, different law firms, accreditation folks, pharmaceutical companies get access to the data. The data goes to a lot more commercial entities than you might think that it ends up going to. In so-called anonymous form, you'll see right in the middle the data, the discharge data to the state. That's one place that Dr. Sweeney has been working and showing that by disclosing that data, which eventually becomes public record, and combining that with newspaper reports, for example, it's relatively easy for, she found someone that she was able to hire and pay, I think, $8 an hour, not an expert in re-identification, was able to perform the task of figuring out what health records came from and what incident that was related to. So right now, in the US anyway, these are all the places that your data would go if you went to see a healthcare provider. I've talked to a lot of patients in the work that I do. None of them think that this is the current case. Nobody that I talk to believe that this is where all of their health data are going. Most of them have the idea that their doctor, maybe the nurses in the office that they go to have access to that data, and some of them want other doctors, other specialists that they're seeing to be able to have access to it, but they have no idea that all of these different providers have access to that information. So to summarize what I was talking about there, the idea is that we can use health information for all of these wonderful purposes. On the other hand, people have to be willing to give us their data. And the worry that I have right now is, given what we're doing with all of their data, why would people want to continue giving us their data? Why wouldn't they start saying, no, you know what, I'm not going to tell you everything about me. I'm not going to let you capture all of that. I'm not going to be totally forthcoming with you as my care provider because you're not sticking with that Hippocratic Oath that you told me you were going to. You're not keeping up your end of the bargain and keeping that information private. And the concern that I have is that people will start providing fake data. So they'll say, I don't have this symptom, I don't have this disease. They'll start lying to their physicians and their care providers, and that's potentially where we end up with data on the back end that's really hard to deal with. We don't know what to do with that. If people are giving us data that aren't useful, that can end up sort of poisoning our whole well of health information that otherwise we could really use for good, right, for population health purposes. So the key to getting good data in the health information space is to provide the privacy that patients expect and want in terms of a healthcare encounter and ongoing. But privacy is pretty hard. I've been working in this space for almost a decade now, and a lot of other really, really smart people have been working in this area for a long time, and it's hard to design privacy-enhancing technologies, privacy-preserving technologies from a design perspective. This is one of my favorite quotes from designers who are dealing with privacy issues, that they say, we just really don't understand privacy in a way that lets us design impactful choice technologies. The approach that I've taken to understanding privacy is sort of inspired by a psychological perspective. It focuses on behaviors. So psychology is the scientific study of human behavior. And so the way that I approach this is by understanding privacy-enhancing behaviors. Those are behaviors that people engage in when they're trying to preserve their own privacy. So one of the things that I'm really interested in are what are users' everyday privacy behaviors, and whether those privacy behaviors differ across different kinds of technologies. This is my very old at this point, but favorite still, privacy-enhancing behavior, because usually audiences understand what it is. I have seen it grow in popularity over the time I've been using this slide hugely. When I started using this slide in 2008 or 2007 maybe even, I did not see anybody doing this. This is actually my cousin's laptop, and what she has here is a very small little cute alien covering over her webcam. And when I saw this, I asked her what was going on, why did she have this there, and she said, well, I'm not certain that someone's not looking in, watching me with my laptop. I have it open in my room all the time. I just keep it on all the time, and I keep it open, and it's not clear to me whether someone might be using this to look in on me. And I thought that was a really interesting example of a privacy-enhancing behavior. So her solution to a technology that did not accommodate the privacy preferences that she had was to now basically make her webcam useless. I personally have a little Post-it note over mine because the sticky on the Post-it note is easy to remove and it doesn't gunk up my camera, but she simply couldn't use the webcam function of this. Okay, so that's one example of a privacy-enhancing behavior. I've categorized, this is a study I won't be able to go into for time purposes, but in my dissertation I categorized a number of privacy-enhancing behaviors and ended up with sort of 3 categories of privacy-enhancing behaviors that emerged from the data. These were avoidance behaviors, modification behaviors, and alleviatory behaviors. Avoidance behaviors are behaviors that people engage in sort of before the fact, before they're in a position where they would have to disclose something that they wouldn't like to or that they felt their privacy might be invaded. This could be something like the example that I think is really interesting from a psychological perspective is censoring theirself. So I had a meeting with students earlier and we were talking about this, where we might, instead of saying something and feeling free to really think through a topic and really consider something in depth and say what we're interested in out loud, instead we'll keep that to ourselves and not really let ourselves get into that as much as we might want to. And that has interesting psychological consequences, certainly. Modification, the one that I think is really interesting there is people will engage in sort of being vague about things. So instead of being very specific about what they want to say, if they want more privacy from a technology, they will be quite vague in the information that they reveal. So you can imagine in a doctor's office, if someone asked you your age, this is a natural thing, you might say exactly your age. You might say, okay, well, I'm 30 years old, instead of saying the exact day, month, and year that you were born, which is a more specific sort of way to give the exact same information. Alleviatory behaviors are those that occur after a revelation, so after you've disclosed some information. They're one that's relevant for social network behavior, for example, is asking someone to remove or asking them to take something down that's posted about you. Again, I'm not going to go into these in too much more detail than that, but this is the framework that I use to look at and understand privacy-enhancing behaviors and sort of predict what might happen across different kinds of technologies. And indeed, what I found was somewhat disturbing to me. I found that, in fact, when I looked at health disclosure settings, the 2 most commonly occurring types of behaviors were avoidance behaviors and modification behaviors, which are arguably the potentially most dangerous in terms of people receiving quality care from their healthcare provider. So if, in terms of health behavior, if I avoid, that means I'm not revealing to my provider what is really going on with me. So I'm either not telling them about some previous health experience that I've had, or I'm not telling them about some medication that I used to take or some medication that I'm taking now. That can be for a variety of reasons. Modification behavior can be, again, being vague about what's going on with you. So perhaps in a mental health scenario, you could say, well, I'm not feeling that great, rather than being very specific about depression symptoms, for example. So these were the 2 leading types of privacy-enhancing behaviors that people said that they engaged in when they were in a health setting. The California Healthcare Foundation conducted a survey, actually earlier than mine, that I found that said that 1 in 8 people engaged in a behavior intended to protect their health privacy. These kinds of behaviors were asking doctors not to record a specific health condition or record a less serious or less embarrassing diagnosis in their health record, or going to a different doctor than their normal doctor and telling the separate doctor something different than their regular condition, or personally paid for a test to avoid having an insurance company know that that test had actually occurred. So taking all of this that I've sort of set up for you into account, I'm now getting you to the point of design. So the next goal that I had was to, working with a team at Regan Street Institute and Indiana School of Medicine, help design a privacy-enhanced electronic medical record. So given that we want people to share with their providers, we want them to give good, accurate data to their providers, and we also want to provide them a level of privacy, the level of privacy required for them to feel comfortable giving their providers that kind of information. We had to design a privacy-enhanced electronic medical record or electronic health record. So our goal was to do this from a user interface perspective. We wanted to develop a usable browser-based user interface for granular patient control. The team that I worked on was a pretty cool team because we had all of these different people from different multidisciplinary team working on the project. So we had ethicists, medical ethicists, we had a human factors team, we had a whole team of medical informaticians, we had MDs, and we were also taking into account, based on some things from the grant that we received for the project, the fair information practices, which are a set of practices that help guide designers in terms of designing privacy-enhanced systems. So all of this was to say that we were going to try to design a usable browser-based system where people could go in and share or not share different elements of their health information that allowed patients to have control over their own privacy. Before we got into the design process, we needed to understand first, well, do patients really desire control to determine at a granular level what personal information they would like to share and with whom, and also for what purpose? And then what are the user interface options that we could eventually test to determine which one of those would work the best to allow patients to achieve that granular control that we hypothesized they might want? The method that we used was a sharing preferences task and a contextual interview task. The sharing preferences task is a form of card sort where patients matched potential recipients to potential types of information, and the contextual interview was an interview that we conducted in a provider's office to let patients, to have a more accurate representation of patients being in the mindset of being at a provider's office while they were discussing these topics with us. And what we have here is, sorry, I'm not on the other side, so it's a little bit hard. On the y-axis, you have the percent of items that people preferred to share, and across the x, you have different potential recipients. So along the bottom, you can see that the primary care physician had the highest percentage of items that people would want to share. And sorry, I should have pointed out the different color bars there. The black is for patients whose records contained only less sensitive information in the records, and the gray is for patients whose record contained highly sensitive information. The way we defined highly sensitive information was based on a categorization by the National Committee on Vital and Health Statistics, who suggested a number of items, for example, HIV status, sexual health information, mental health conditions, as being particularly sensitive items that might be an electronic medical record. On the other hand, something like whether or not you've gotten a flu shot is considered less sensitive than these highly sensitive bits. So, the big takeaway from this was there were no participants in the study that wanted to share all of the items in their record with all of the potential recipients that we asked about. Most people, in fact, all of the people who only had less sensitive items in their record were fine with sharing everything in their record with their primary care physician. However, that preference dramatically decreased when we started talking about nurses, especially for people with highly sensitive information in their record, for nurses, for pharmacists, for insurance companies, for family members, for research purposes, and for non-treating physicians. So what we found in answer to our research question was, yes, actually patients do desire a level of granular control when with respect to what personal information should be shared. When we're asking who would they like to share personal health information with, well, those preferences differ dramatically across who you're asking about. So across the type of recipient that would potentially receive that information, it was hugely different. And it also differed according to the sensitivity of the records. So to address the question of for what purpose, why is this what patients want, we went to the qualitative data from the contextual interview.
Just a good question. So
Sure.
The data there, the way you collected it, did you ask specific questions about certain things?
We used a card sort method. Oh, sorry. The question that you asked was how did we collect the data?
I'm just curious about the nature of it, because one wonders why someone would be less comfortable with a nurse knowing something than the primary care family doctor.
Right, so I'm repeating the question for the group. The question is about, you're not sure why someone might be less willing to share their data with a nurse versus a patient. Let me get to the first part of your question, which was how do we collect the data? And the way that we collected this data was using essentially a modified card sort technique. And what happened was patients were given sets of cards with recipients, all of the recipients that you saw here across the bottom, and then different elements, so things that were representative of elements that might be an electronic medical record. So HIV status, for example, domestic violence status, these sorts of things. And we asked them to match who should get this information. Okay, so it was a very specific task to find out exactly what their preferences were. In terms of your second question about why is it that they might want to share with a provider, with a physician rather than a nurse, for example, that's where a little bit more of the qualitative data comes in, so we can talk about that. One of the big themes that came out of the qualitative interviews was that access should be on a need-to-know basis. Specifically, people should be able to get information about me when they're using it specifically for my treatment. So one patient said, there's just so much stuff in my medical record, right? This participant got the idea that medical records contain a huge amount of information about people. And she said, I wouldn't want everybody to see all that. So I want my physician who's providing me care to have access to that relevant data, but I don't want everybody to see everything that's in that record. One patient put it very specifically, I don't think my eye doctor needs to know about the gynecological health of me to provide me, to tell what glasses prescription that I need. So the access should be on a need-to-know basis, specifically for treatment and not just across the board, all providers get access to everything that's in a record. And I'll point out later, but I'll just briefly mention here, the systems that are currently being designed and deployed by default provide access to all providers. So everything that's in your record is by default shared with all providers. There are mechanisms to check up and make sure that people are not accessing records that they shouldn't, but the by default settings right now are that all records are shared. And this is completely contrary to how patients think that systems should work. Sure.
But like comment from P5, thing is, it could be that something from the gynecological record is actually affecting something down here is affecting this. So,
Right. So the question is, it's possible that a patient isn't the best judge of what information is relevant to a particular care provider. And I think that's absolutely right, and this decision shouldn't be left up 100% to the patients either. On the other hand, it's also quite possible that in 99.999% of the cases, that is not relevant information for a doctor to have.
But the thing is, the reason that by default, for a healthcare provider, everything is available may be specifically, I mean, there are two reasons. One is that it may have been too difficult to divide the data up into chunks. But also it may be that medically we don't know what the full effects are, so it's best just to leave it.
Right, and so the comment is we might not necessarily know, so it's best to potentially design it by default to share all information with every provider. And I would say that the response to that is, well, right now, the way that current medicine is practiced, or 5 years ago before we had electronic medical records, you had to go to your doctor's office, you had to ask for your paper records, you had to walk them over to your new provider's office, and you had to hand them to your new provider. And to change between that level of intentionality of sharing sharing each different piece of our medical record to a place where 100% of the information is absolutely shared by default without considering what a more nuanced solution that incorporates patients' preferences might be, would potentially run into some of those consequences that I talked about at the beginning, where patients don't expect or don't want that to be the case and have explicitly engaged in behaviors that would prevent a new provider from seeing certain pieces of information. And if they are acting autonomously and considering that and saying, I am exerting my privacy preferences, this is exactly what I want, then it's an open ethics question, and I have the ethics members on my team have been very thoughtfully considering this. How do we weigh this from a medical ethics perspective? Is it more important to give patients autonomy, or is it more important that the doctors have complete autonomy and that the patients don't get to choose at all whether information is shared with them about everything in their record with every potential provider? So, but I think hopefully we'll get to some potential UI solutions to this later on down the road. Another theme that came out in the interviews was that patients really wanted to have access to their own health records. This is not some brand new novel finding that nobody else has ever found, but it's confirming other literature that has suggested from the past that people really would like to have access to their own electronic medical records. And currently, of the 30 participants that we interviewed, 26 said they would really like to have access. None of them said no, they didn't want to have access. And people gave a variety of reasons for saying why they would like to have access to their medical record. Some were simply interested. Others, specifically some who had had difficulties with medical professionals in the past, wanted to check the accuracy of their records. So some people had been had issues with things being in their record that they didn't feel accurately represented the situation that they were in. So this person says, the thing that upsets me is inaccuracy. If I knew that what's in a record immediately, I could sort of correct it before I'd have to contest it later on. So this participant had actually gotten her paper records, had found inaccuracies, and had to go through this very lengthy, drawn-out process of contesting bits of her medical record that were causing her harm when she went to seek care. Yes,
sorry,
that's okay.
Maybe you said this, but were the participants shown some representation of what's in their record before this exercise started, or no? They just were to imagine what they thought was in there and base it on that piece of it?
The question is, were patients shown a representation of what's in their electronic medical record? No, we did not show patients what was in their medical record. Like you, some of them had seen what's in their medical record, and some had not seen what's in their medical record. All of them wanted to have access to their medical record. Yeah. So when we asked people, and this gets at your question too, this next slide, because when we asked people what it is that's in their record, a third of them said, I have absolutely no idea what's in my record. I have no clue. 2 of our participants had a good idea. I think it's one of the ones that I talked about before that had inaccuracies in their record before she knew. When we asked how far does your record go back, we got a wide variety of answers. Some people just really said, I don't know, I have no idea. Some people thought that the medical record went back to when they saw a particular physician, and some people had the idea that their medical record had been collected as a whole about them since childhood, which is absolutely not the case. There's no, at least at this point, there are no records from childhood about people. 2/3 of people had no idea who has access to their health records. 6 people said they had some general idea. When we asked them about whether or not they were concerned about their privacy, also about 2/3 said yes. And the reasons that they gave often had to do with fear of negative consequences from the things that were in their record. So for example, this person was worried about insurance companies having access to their record and not covering you. This is a difference between Canada and the United States. Potentially, we've dealt with it in the US, it's unclear at this point, but with the Affordable Care Act passage, at this point we may have a situation where patients don't have to worry about not getting health care for fear of a pre-existing condition. But I imagine if I conducted the study here in Canada, I wouldn't have had the same concerns that people had that told me in the US about being worried about being excluded from insurance for fear of pre-existing conditions. However, I will say that people were worried about other types of insurance too. They were worried about sort of life insurance and car insurance and those companies having access to their health record as well.
But was that the only thing?
Sorry?
Was that the only concern?
No, this is just an example of one of the people had other privacy concerns about it. So to sum up here, we did find that people wanted granular control over the data in their medical records. They would like to be able to set different privacy settings across different types of recipients and different types of data, highly sensitive information versus less sensitive information. And the large purpose that came across in the data was that people really wanted their data to be used specifically for their own treatment. If you'll think back to the chart that I showed you, you'll remember, researchers were very low. People said, by default, my information should generally not be shared with researchers. However, when we followed up with people and asked about that, they said, oh, well, yeah, if you want to run a specific study and I can help with that, I would be willing to, give you access to my record for that specific study. But they wanted to be, in any other cases besides when it was used for their own care, for their own treatment, they wanted to be asked whether or not their data should be used. So this has a number of implications in terms of the design of a privacy-enhanced electronic health record. Anytime, if we're going to design a privacy-enhanced electronic medical record, we should make sure that we provide patients access to their own records. That access should be immediate, timely. They should be able to go to the doctor and then come home and find out what was recorded about them so they can check that for accuracy, and also to make, it can serve as a communication enhancing tool between patients and providers. We should also provide granular level control for patients to determine what recipients should receive access to each piece of data. One thing that we found was that their preferences varied patient to patient. It wasn't so simple as, okay, everything that the MVCHS considers sensitive, highly sensitive information, we should just keep all of that information, private, and then share all of the less sensitive information. It wasn't so simple. One participant thought domestic violence information was very, very sensitive and didn't want that to be shared, while another participant would think mental health information was very sensitive. Other participants thought some things that the MVCHS didn't even consider representative of highly sensitive information, particularly sensitive, and didn't want that shared. That's another reason why granular control is a potential solution to this.
I have a feeling that the reason for the distinction between people's concern about different parts being sensitive is that, okay, if I don't have any mental problem, then my mental information is not sensitive because I know there's nothing. So I think perhaps the choices there reflect what they know about themselves.
So the hypothesis is that the differences were related to whether or not people had specific elements or sensitive elements in their record. I think we could do more to explore that. However, there were differences even with people who didn't have any of the information that was considered highly sensitive in their records. Those people thought...
Not the information that is in, but what you know about your own condition. If I'm having mental problems, I wouldn't want anything about my mental condition to be public, whether it's in the record or not. That's the thing. Not what's in the record, but what they know about themselves.
Okay, so the concern is, or again, the hypothesis is if people know this about themselves or they have something in their record, they might feel specifically that that information is potentially private. I think we could talk more about that, offline. So that was, I mentioned about sort of beyond the category level. So patients will want to have preferences or be able to set preferences beyond just a category level. It's not sufficient to say, okay, all sexual health information or all domestic violence or all mental health information. They would like to be able to set settings at a more granular level than that. Another thing that came out in our interviews was that time-based controls is a potential solution for this, where patients can say, okay, you know what, anything that's more than 5 years ago, that's not relevant to my current care, or I would like to exclude provider access to information that's more than 5 years old about me. So that's a potential. Nothing before I was 18 or nothing before I was 21. Or when they're seeing a new provider, for example, I'm having this knee issue, so I want my new doctor to see everything in my health record that's over the last 6 months, okay, as a way to really make a big chunk in terms of the information that they wanted to share versus information that they didn't want to share. Another thing that came out was that a potential way to enhance patients' trust in their providers was providing visualization of when providers accessed their records. So, for example, if I go to a new doctor and the doctor looks over my health record, I would like to have that information available to me. On the other hand, if I have not seen a new doctor anytime recently and I am looking at my record and I see that a new doctor has seen my record, I would maybe explore why that new physician that I've never had any contact with is looking at my record, potentially figure out why that might be occurring. Perhaps it's a very reasonable thing. Perhaps my doctor has a colleague that he would like a second opinion about, but patients thought that could facilitate trust with their providers. And along the same lines, kind of access notification, they would like to have some sort of way to be notified when their records were accessed. So, this is an example of an electronic health record user interface. It is hard for me to figure out what's going on here. I'm not really sure. There's a lot going on here. This is not a simple, easy to digest user interface. This is the kind of thing that we're sort of starting with. So we started exploring kind of other user interfaces for sharing. This is a Facebook preferences setting window for privacy preferences. We also felt like this maybe wasn't the best place to start. It was pretty hard for people to use, or I don't know if hard is the right way to put it. It was specifically designed so that people would share more, right? And we were interested in designing a user interface that afforded people the ability to set their preferences to set settings that exactly matched their preferences rather than set settings that were different than what they really preferred. So we ended up hiring a design firm just down the road a little bit in Michigan, and we used the data from the contextual interviews and from the card sort that we had performed, and we had a big design session, and we came up with a huge number of potential solutions to all of the things that I talked about before, and I'll go over some of those now. I think about these as the elements, the design elements or the user interface elements of a privacy-enhanced electronic medical record. Our first point was to provide meaningful access to records. So instead of having a really difficult to understand user interface like I showed you a couple slides back, we wanted to show people in a time-oriented, sort of temporal fashion, what are the things that have come into your medical record recently and have sort of embedded privacy controls within that. So this gives an overview of what's in a patient's record, versus, I can tell you, versus what's currently available, which is a stack of papers that you have to request from each of the different providers that you have. If we had something like this, it would be a huge step forward in terms of usability. We wanted to be able to provide granular hierarchical controls in terms of the privacy settings. So here you can see that different elements of a medical record at a categorical level at first. You're able to make privacy decisions from all the way from, no, I don't want this piece of information shared with any recipients, all the way to this information can be shared throughout the health network or the health system, and people can make those decisions at a categorical level, and then they can also dive deeper down and make that at each element level. So a particular test result level, they could make those decisions individually. We also wanted to be able to afford patients a way to set limits with their records. So if they wanted to have their data only reflect, for example, information since they turned 18 or information for the last 6 months, we had a simple clickable interface here that they could set those time limits. We also wanted to provide information in context. So all of the controls have a contextual element where when patients are looking specifically at their record, they can make changes to the privacy settings at that level, so at the record level. When they're glancing over their record, they can, at that moment, rather than in a separate privacy setting interface that was specifically designed for privacy settings changes, this would allow them to make the changes also in the context of their electronic health record. We also wanted to provide access notification to them. So you'll see here that some information, for example, is automatically shared with different agencies. For example, insurance agencies, if you receive care that you haven't paid for with cash, an insurance company is going to get that information automatically. Also, state public health agencies receive certain information automatically, and we wanted patients to understand that they could set settings for some things, but on the other hand, some information was simply shared no matter what their preference was. We thought that was an important element. We also provided them access notification. So what you see here are sort of the 25 most recent access log to their data bubbling up from the bottom, and then also kind of a chart that says these are generally the people who are accessing your record that you can get at in a kind of glanceable way. Another question that we were really interested in was the information architecture of how we should design this system. So if you're designing a hierarchical system, you need to understand, or a hierarchical user interface, you need to understand what elements should go sort of underneath the hierarchy. We could have just used what medical providers would use and say, okay, flu always goes under communicable diseases. But that's not how patients think about health information. So we conducted a card sort, an open card sort, and asked patients to take a number of recipients and also take a number of health information elements and sort those into groups and then name those different groups. And I'll just get right to the dendrogram that resulted from the card sort. What this did is essentially a factor analysis, and it placed the items that were most commonly grouped together by patients close in space and the items that were very rarely grouped together by patients very far apart in space. So it's very small on my screen. It's also small here. You can see, for example, that chiropractor and mind-body therapists and homeopaths were all grouped together very commonly by people, whereas that was not commonly grouped with a spouse or child as being a potential recipient of data. We did the same thing for elements. This is types of information that would go into a health record. So here you can see that, for example, something like your allergies would be very different than a piece of data, a demographic information like your date of birth. So those two items were never grouped together. We used these two things in combination to develop paper prototypes that we then tested with users. This is a paper prototype that was designed and built by a student at Indiana. Her name is Shen. And then we engaged in an iterative design process where we created a new paper prototype, had a participant interact with that prototype, noted places where the participant was confused, had trouble, made design changes, and completed this cycle many, many times over, refined and tested. This is the latest version of the sharing interface. It is not complete, but it's where we are right now. We're currently conducting usability tests with a live web version of this, which is how we imagine it being implemented in a health system, for example, at the Regenstrief Institute, which is the collaborators that I conducted this research with. We imagine the top section as being a way to visualize who has access to different elements of a record, and then also providing all of those different elements that make up a privacy-enhanced electronic health record that I described before. So to wrap up, I just want to go back to that thing that I told you at the very beginning that I spent the beginning of the talk on, to say, why is it that it's really important for us to consider privacy in terms of electronic medical record design? Well, if people aren't satisfied with the level of privacy that we provide them in a system, they're going to use workarounds, right? They're going to engage in privacy-enhancing behaviors. They're going to self-censor. They're going to refuse to reveal critical information to their providers, because people will engage in privacy-enhancing behaviors when technology doesn't fit their privacy preferences. These behaviors can really undermine the care that they receive, not only individually, but also potentially at a population level. If we get bad data in now as we're designing sort of systems at a population health level, we won't be able to perform the population level studies that we would like to, that we feel like can eventually improve care down the road. By taking a human-centered approach to this problem, we can design privacy-enhancing tools that can fit users' needs and hopefully help build a privacy-enhanced electronic medical record. I would like to acknowledge my collaborators. This is definitely not something that I did by myself. I am very lucky to have fantastic collaborators, both in terms of students. I had two wonderful postdocs who worked on this project, Carrie Lawrence and Rima Hanania. Also Spencer Cohn at Clemson and Shan Ling, who did some of the design work that you saw there, and collaborators at Regenstrief Institute and Indiana School of Medicine, Bill Tierney, Eric Meslin, Sherry Alpert, and quite a few other team members. That was a really big team, and it's been a wonderful experience working with them, and then also members of the lab. With that, I'll be happy to take any questions for the next 5 minutes. Yes.
So your system is based upon the assumption that the user, the patient, so as to speak, is in the best position to make a judgment about what records he has to be writing. And your research also shows that patients share the most, they're most close to the primary care provider, the physician. Do you think it makes sense to include the physician in the process of taking judgment about what information should a patient actually put on his record or not? Because like we saw the example of the eye and the gynecological problems. Maybe the patients are not always in the best position to make calls about what they should report or not. And because it was the physician, maybe it makes sense to involve the physician in the process of doing that.
So the question is that it seemed like, I'm going to phrase what you said, it sounds like I put patients totally in control,
Right.
and that maybe we should have a physician in the loop.
Because that's only considered the most comfortable in sharing.
And a physician should be in the loop because maybe they're more competent at making these privacy decisions. So a couple things. One thing is currently, the current system that all of us are living in and not dying and doing all right is that physicians do not have access to everything that has ever happened to us in our entire life. So we need to consider very carefully if we want to drastically change our system that much, that goes from I have right now as a patient total control over the privacy that I'm afforded when I see a new physician, to the complete opposite of that, which is that physicians are in total control over whether I have any choice about any records in the past. I certainly think physicians should be involved here, and one of the findings from the qualitative work was that patients are willing to share everything in their medical record with somebody who's providing them care. Right? They're willing to say, okay, this is a doctor that's trying to help me, I have something going on, and they need to see everything in my record. All of the patients were fine with that being the case. The thing is, they wanted to be aware of who was accessing their record, and they wanted to have some say over who got to access their record. So they didn't just want everybody in the medical field to have access to all of their information by default. They were willing to share it if it was needed, but they didn't want to feel like their needs or their desires weren't even considered in that design process. And I hope that that's what this work brings to the table. There are, like I mentioned, there are ethicists who are considering this, there are information technologists, there are physicians. This is the patient side of it, and it's not the only consideration. We should think about all of these different considerations. It's just one piece of it. But to change from what we have now, which is 100% patient control over what records are shared with new providers, to the exact opposite of that, I think we should really consider whether or not that's the right, move. Yes?
So it seems that the doctor knowing everything can only help you, whereas the insurance company knowing everything might not help you. So do you think it'd be more likely people would share if there was no negative consequences of sharing? Like, was it legal for an insurance company to deny you insurance for any existing conditions?
Sure. The question is, do I think that there would be different preferences if there were no negative consequences from sharing everything? The answer to that very specific question is yes. If there were no negative consequences foreseeable ever, I do think that would change people's perceptions. However, I will say that I don't think you and I can always figure out what the negative consequences are for everybody else. So I wouldn't want my own preferences about sharing my information to apply to everybody else without a very serious study about what everybody else might want. So, for example, there was one participant in this study who had experiences where there was incorrect information in her record, and she had experienced negative consequences from a physician who treated her differently because she had something that wasn't right in her record. There are a lot of examples of things like that might happen. I have never been in a situation where a provider treated me poorly because they thought I had a mental condition, or maybe somebody that did have a mental condition. But there are an unknowable number of reasons why people might want to keep information about themselves private, and this is the way that we can provide them an ability to make their choices for themselves. Remember, this, an interface like this totally allows you to share everything with every provider that you want. It's very easy to do that, but it also does allow you to share or keep bits of information that you don't want shared with everybody as well. Kat?
So, are you aware of any work, or do you have an intuition? Going back to Latanya's slide that listed all these different companies, many of them for-profit companies that by default have information or can get information. Do you think that there's hope for giving patients the ability to decide for themselves, when on the other side are giant corporations that want to make money and want to monetize your data?
Okay, the question is, do I think there's hope in keeping patient data from giant corporations that want to monetize their data? I think that providing awareness to people about where their information is shared automatically, that they currently don't have any choice, is a way to potentially affect policy that might change that. So one of the things that this system does is make people aware of where their information is going. It helps them see where their information is going. And so my hope is that if people see where their information is going and it doesn't fit with what they thought or what they wanted, then they might take action as a group to try to change that.
Okay, we're out of time, so let's thank everybody again.